الله الرحمن الرحيم. هنكمل بقيه السيشنز بتاعت اليوم ان شاء الله. السيشن extending for 2 hours باذن الله بعنوان navigating overlooked gynecological conditions. هنستمع اول سبيكر الحقيقه الاميننت سبيكر بروفيسور عمرو الشلقاني. بروفيسور عمرو الشلقاني is professor of obstetrics and gynecology. We has special interest في gynecological oncology. Is former head of the 4th unit في عين شمس University و former head بتاع الأونكولوجي unit. The title of the talk is lymphadenectomy in endometrial cancer. To do or not to do.
هذا progress ده هو اللي بنعاد اقول next هقول next ان شاء الله. بسم الله الرحمن الرحيم. Next please. First of all, I'd like to thank the organizers of our dear department of Gynecology at Ain Shams University. Many thanks to the chairman, Professor Amr Al-Husseini, and the chairman of the meeting, Professor Hatem Al-Gamal, and congratulate them on the good attendance. I would like to start by inviting you to the coming meeting of the Egyptian Fertility Study Society, the 30th International Conference that will be held in the Marriott Hotel 28th, 29th of November this year. And we promise you with an excellent scientific program. الصمت الرهيب. لا واضح. بس هو مفيش هنا حاجه ولا هنا. طيب لا لا لا
انتوا مش هتكملوا الفصل ده. هو الفصل ده
مش تبعهم. انا عندي بس مش شغال. لا مش شغال. اللي عندي مش شغال. خلاص انا هكمل هنا بس عشان لحد ما تشتغل لحد ربنا ييسر ان شاء الله. No conflict of interest to declare at this point. I actually will start by telling my conclusions. So to start with, actually, the role of systemic lymphadenectomy in endometrial cancer is fading away or is coming to an end. It was incorporated into the standard of care based on low quality evidence and expert opinion. There is no evidence of its value from randomized controlled studies in early endometrial cancer. And lymph node involvement is a prognostic marker. It is not a therapeutic step. And the information getting from the lymph node dissection can be acquired from other prognostic markers like radiologic, molecular, and histopathologic immunohistochemical. The only therapeutic value may be in the removal of bulky nodes. The use of sentinel lymph node biopsy is like a trade-off. حاجة أقل شوية في العلم بتاعها instead of the more morbid systemic lymphadenectomy. The advent of novel adjuvant therapeutic options like radiotherapy delivery systems, targeted therapy, immunotherapy, and new ways of drug resistance management, better delivery systems like antibody drug conjugates, is another way that the value of lymphadenectomy will vanish. The near future will be probably for machine learning and artificial intelligence for developing management models to define the most precise course of diagnostic and definitive adjuvant therapies for every individual patient with endometrial cancer. I'm just putting here the word panoramic, omics. The different omics of the patient is the best prognostic and the best precise therapeutic management defining. Endometrial cancer actually is the sixth worldwide, and usually around 500,000 are reported every year. And in the United States, there is annually 60,000 cases reported, and it is expected to double within the coming 6 years. And the annual increase is around 2% every year. So actually, we're talking about a significant problem worldwide. And there is evidence actually that over 30 years, from the year 1988 until the year 2016, there has been a rise in the incidence of endometrial cancer for women below the age of 45 by 14-fold, 14 ضعف. And for women between the age of 45 to 54 by 63-fold, 63 ضعف زيادة. And for women above the age of 55, there is a 50 times increase in the incidence of endometrial cancer. So we're talking about a grave problem actually to deal with endometrial cancer, which is expected to increase. When less is more and lessons learned from breast cancer, unfortunately, our specialty in gynecology comes late in the development of various therapeutic and diagnostic models. So actually, from breast cancer, we learned actually that there is no evidence that the more radical surgery and the more nodes you remove actually is going to affect the chance of overall survival or decrease the chance of recurrence. And this comes early as at the year 2002, where total mastectomy without axillary dissection is having the same survival like radical mastectomy or total mastectomy with axillary node dissection. Another trial actually from the United States, the ZOO11 from the American College of Surgeon and Oncology Group, indicated that if you perform sentinel lymph node dissection only or followed by added axillary lymphadenectomy, there is no added value for the removal of extra lymph nodes. And this actually has been proved through the years, and even with a longer follow-up, you can see that the overall survival and the recurrence-free survival and even regional control are not different over the years. Which means actually the less you remove from lymph nodes, there is no whatsoever difference on the survival. Actually, I was trained at a time when we used to describe the efficiency of the procedure by the removal of more number of lymph nodes, which proved to be an extremely wrong concept. And this actually just to show you that either the systemic lymphadenectomy in breast cancer or sentinel lymph node dissection, there is no difference. And what matters as well, that this study did show that other factors are more determinant of the survival or the recurrence. And at the top of them are the hormonal receptor status for breast cancer, which means actually it's not the lymphadenectomy or the degree of the lymphadenectomy, but the characteristic, the molecular characteristics of the tumor. So what's the evidence in endometrial cancer? We have actually two big, this actually was the old endometrial cancer staging in the year 1988. And this was the first to state for the surgical staging and adds a point for describing stage 3C by having pelvic or para-aortic lymph nodes. And this actually was built on in the year 2009, where there has been two different categories for pelvic nodes on its own and for para-aortic lymph nodes, whether alone or with pelvic lymph nodes, 3C1 and 3C2. So there has been a consistent, actually, guidance that you perform lymphadenectomy. And at that time, this would be first trial actually looking at randomized trial at the value of lymphadenectomy in endometrial cancer. And as you would see, there was no survival benefit whatsoever for the lymphadenectomy group. And the recurrence-free survival was slightly higher even in the no lymphadenectomy arm. So the benefit actually is more in the no lymphadenectomy arm. And this is probably, these patients are having extra types of adjuvant therapies. The same actually was confirmed by this Italian study that was released actually in the year 2008. And as you would see, the large numbers, 514, and randomly assigned to lymphadenectomy or no lymphadenectomy. And as you see, the 5-year disease and overall survival between the two groups didn't show any survival benefit for the lymphadenectomy. And as well, the same trial did publish as well about the complications, and they indicated that there is a significant morbidity, operative and late post-operative, related to the lymphadenectomy. The Cochrane review actually, when looked at the various slides, they amalgamated and pulled the whole data from these two trials. And as you see, we found no difference in the surgical morbidity, but the women who had underwent lymphadenectomy had a higher risk of surgery-related systemic morbidity, and there was no difference in overall survival between those who had the lymphadenectomy or did not have the lymphadenectomy. So the evidence from randomized trial is absent. This actually is the third randomized trial coming from Mansoura, and actually they randomized only 38 patients, and there is a great concern about the data to be included in any meta. It has been excluded repeatedly from any analysis. Lymphadenectomy as well has an impact on the long-term morbidity. We're not talking about a step in the procedure that actually appears to be useless, but you're leaving some harm to the patient to live with. And this actually is one of the studies that even indicated on the long term that the survival is better in the women who had not had the lymphadenectomy. The red one above. So is sentinel lymph node identification and biopsy is the solution? We're talking that identification of lymph nodes in all is not helpful. So people tried actually to keep the same principle without having any evidence behind it, but tried to decrease the complications of the lymphadenectomy. So there has been a move towards mapping of the sentinel lymph node, the first lymph node draining the uterus. And there has been 3 studies. And this is the principle. It can be a trade-off, نوع من المقايضة. بدل ما نعمل الليمفادينكتومي الكامل، لا نشيل غدة واحدة أو 2. And there has been 3 studies. This is the earliest one from France. And they said that the conclusion, it can be a trade-off between systemic lymphadenectomy and no dissection at all. يعني مرحلة في النص كده. هم مش عايزين يشيلوا البرنسبل خالص، خليه موجود بس نعمل حاجة أخف. And we have to understand that sentinel node mapping in the 3 studies I'm going to present is between 88 to 90%. يعني في 10 ل 12% من العيانين ما بنعرفش نطلع فيهم sentinel lymph node. So what to do with this patient? This is the second study from the United States, and it has been all done by the laparoscope, having the same thing actually, that the incidence of positive lymph nodes is between 12 to 14%, and there is actually a chance of having no sentinel lymph node about 10 to 12%. This is the third study from Scandinavia, and all these women have been actually operated upon by the robot. And again, they are stating the same thing, that sentinel lymph node is a good chance for minimizing the morbidity of lymphadenectomy. Here we're talking, the value is minimizing the morbidity of lymphadenectomy, and there is a chance again of negative mapping by 10 to 12%. This actually is one of the latest studies coming from Lübeck in Germany. And again, they are performing the sentinel lymph node in the early endometrial cancer. And with a complete sensitivity to detect pelvic lymph node, they discovered that pelvic lymph node organs in the hands of experienced surgeons exclude the overall nodal environment. And they stated that probably negative sentinel lymph node is having 100%. يعني لو طلعت sentinel lymph node ونيجاتيف, the chance ان هي تبقى 100% ما فيش اي lymph node اخرى affected. This is actually a later assessment of the three techniques, whether you perform the systemic lymphadenectomy or the sentinel lymph node lymphadenectomy followed by lymphadenectomy or sentinel lymph node lymphadenectomy at all. And it appears actually from this abstract that was actually published in the proceedings of the American Association of Gynecological Laparoscopists, as you would see that the prevalence of nodal disease was almost the same between 12 and 14%. And the three techniques didn't show significant difference in terms of disease-free survival or overall survival. So the three techniques, whether sentinel lymph node, whether lymphadenectomy, whether sentinel lymph node followed by lymphadenectomy, doesn't alter at all the pathway for survival for this patient. So the question, can we predict the nodal status without the resort to morbid surgery? This is one question. And can we identify more precisely who would benefit from the adjuvant therapy? Because this is the item. Which patients would require further treatment? And do we have an effective adjuvant therapy for positive node patients? And this another important thing, because sometimes you know that your adjuvant treatment is not that efficient. And there has been the paradigm shift. Actually, earlier, actually, we tried to categorize endometrial cancer as type 1 and type 2. And there has been the development of various risk selecting models or specifying models, PORTIC, GOG99, CIPAL, ESMO, and modified ESMO in the year 2014. And again, appeared that none of them is very efficient to define which patients we can allocate actually for doing the lymphadenectomy. And there has been actually a great change in the understanding of endometrial cancer, and I'm sure my colleague, Professor Salah, will talk about that. And there has been a newer molecular subtyping of various types of endometrial cancers. And this actually appeared to be the more or the most determinant of endometrial cancer prognosis. We have the hypermutated, the microsatellite instability or mismatch repair genes, the copy low number or the high copy numbers. And this has been well validated as well in retrospective studies on histological blocks of thousands of patients from 16 countries in the PROMISE trial. And this actually has led, I'm just skipping this because you will have, that the ESGI, the European Society of Gynecology, and the European Society of Therapeutic Radiation Oncology, and European Society of Pathologists to develop actually categorizations for endometrial cancer dependent on the molecular classification. And this was released in the year 2020. There has been a move as well in the FIGO staging in the year 2023 towards the adoption of these molecular subtypes and various histological types of endometrial cancer into the FIGO staging. And again, I will leave it to Professor Salah to underline this. But the whole thing, we are moving to more molecular and histopathological characterization of the endometrial cancer. Again, I'm just reminding you that the 3 lymphadenectomy strategies didn't have any impact on the overall survival from this recent study that was released in the year 2022. And this actually is the latest study actually regarding the use of sentinel lymph node. It's called the Seneca trial that has been published about a month ago. And actually, they looked at the use of the molecular typing in addition to the use of the surgical staging with the sentinel lymph node definition or mapping. And as you would see, it was a retrospective study, 66 centers, 16 countries, and patients underwent surgery with sentinel lymph node assessment according to the ESGO guidelines. And this actually occurred 2 years after the release of the guidelines. So actually they followed the use of molecular typing in the analysis, preoperative samples or hysterectomy specimen. And it appeared that molecular profiling emerges as a predictor of lymph node involvement. And this suggests the potential of molecular classification in the personalization of surgical lymph node staging protocols with endometrial cancer. So again, it appeared that actually the role of lymphadenectomy is about to completely vanish. So I'm repeating my conclusion again that the role of systemic lymphadenectomy in cancer is fading away to a total halt. It was incorporated into the standard of care based on low evidence and expert opinion. There is no evidence of its value in randomized controlled trials at all. And lymph node involvement is a prognostic marker that can be effectively acquired from other prognostic markers. The only therapeutic value may be in the bulky pathological nodes. And it is non-inferior to lymphadenectomy and less morbid. But again, we have to question, is it useful or not? The advent of novel adjuvant therapeutic options like radiotherapy, delivery system, targeted therapy, immunotherapy, antibody drug conjugates is another reason why we will not actually resort to the lymph node dissection. The future will be probably for machine learning and artificial intelligence to be used in the management and define the most precise course for diagnosis and adjuvant treatment for these patients. And remember the word panoramic, the multiplicity of omics that you have to integrate, and this is probably the play of artificial intelligence in the diagnosis and defining the prognosis. And thank you for listening.
Thank you, Professor Amr, for this comprehensive talk. And now allow me to introduce another eminent surgeon, Professor Salah Fayed, Salah Taha Fayed. He was the head of the oncology unit at Ain Shams University. His title is Understanding FIGO Staging 2023 for Endometrial Cancer.
Thank you, Mr. Chairman. انا عارف والله كده ممكن نبدأ كده. بسم الله الرحمن الرحيم. Understanding FIGO Staging 2023 Endometrial Cancer. في الحقيقة أنا لما بدأت أقرأ الستيجنج ده السنة اللي فاتت حسيت إن هو confusing شوية، خصوصا لو كان حد ما هواش Gynecologic Oncologist. الجنرال Gynecologist هيلاقيه perplexing في الحقيقة. That's why إن أنا اخترت هذا الموضوع. Why you are staging cancer? First of all, to unify the language between different concerned doctors. Second, to predict prognosis, because stage is known to be an independent prognostic factor. And lastly, for the research purpose, so that we can pool together patients with the same staging or clinical characteristics together. The first FIGO staging was in 1958, and it was clinical. It was not surgical. I don't think that anyone of the audience will remember it. The second was in 1988, and it was surgical. The third one in 2009 with elimination of the 1C substage. And lastly, in 2023, considering biological aspects. Minor modifications were suggested in between. What are the factors that necessitating new staging? First, we start to appreciate the role of lymphovascular space invasion, which is the presence of clusters of malignant cells inside either lymphatic vessel or vascular vessels. More concern about aggressive histological types. Any gynecological oncologist know for a long time that we are dealing with two types of endometrial cancer, type 1 and type 2, but it was never appearing in the staging. The emergence of molecular biological classification and the era of precision medicine and personalized medicine, so that not all the patients with the same disease will receive the same treatment. It will be tailored according to the genetic makeup of every patient and every tumor. These are the three main pillars that the new staging stands on: the lymphovascular space invasion, the aggressive histological subtype, and the molecular type. FIGO staging 2009. In order to understand the difference, we need to present briefly the 2009 classification. We have here stage 1, tumor confined to the uterine body, no value of histological subtype, only depth of invasion. That's to say, the 2009 staging was purely anatomical. This is either stage 1A or 1B according to depth of invasion, and the C was eliminated. Stage 2, it's only stage 2 with invasion of the cervical stroma without any value of histological subtype and lymphovascular space invasion again. What is meant by lymphovascular space invasion? It is the presence of clusters of malignant cells in endothelial-lined channels, lymphatic or vessel, blood vessel. It is well-recognized independent prognostic factor regarding survival and lymph node recurrence, and it is associated with deep myometrial invasion. In fact, it is not only present or absent, but it could be none, there is no lymphovascular space invasion, or it could be focal invasion, 1 to 3 vessels only per slide, hematoxin and iocine slides, or substantial, equals or more than 4. And in fact, in case of substantial, it increases the risk of recurrence by 8 folds. That's why the ASOGIC guidelines recommend lymphadenectomy in any patient with substantial lymphovascular space invasion, regardless of the histological subtype. And the PORTIC 1 and 2 trials patients who did not receive external beam radiotherapy showed lymph node recurrence in 8 folds in cases of substantial lymphovascular space invasion. This is the picture of of lymphovascular space invasion, the cluster of malignant cells inside the vessel. The histological subtype, for a long time, we know that it is type 1 and type 2. Type 1 is endometrioid, grade 1 and 2. Type 2 could be high-grade endometrioid, which is poorly differentiated, or grade 3, serous, clear cell, or carcinosarcoma. And we know, all of us know that the type 2 carries much worse prognosis, even in the early stages. Type 2 is well known to carry poor prognosis long time ago, although it's not reflected on staging before 2023. In 2023, another type was added, which is the gastrointestinal mucinous variety that has been added to the type 2 and affecting the stage. What about the simultaneous endometrioid adenocarcinoma of the ovary? This is the most confusing part of the staging, in fact. For a long time, we know that it is not uncommon to find an associated ovarian cancer, endometrioid type, associating endometrioid adenocarcinoma of the endometrium. And the histopathologist will have hard time in order to answer the question whether it is a secondary from the primary uterine or endometrial or another dual primary, as we say it. It should be grade 1 or 2. It should not have deep myometrial invasion. It should not have substantial lymphovascular space invasion, and should be endometrioid as well. In the staging 2003, finding a concomitant ovarian and early stage endometrioid adenocarcinoma with this criteria will make it stage 1A3. What about the molecular classification of endometrial cancer? According to the Cancer Genome Atlas, with a large program characterizing the sequence of different tumors, 4 molecular varieties, as Professor Amr said, have been described and well known to have prognostic significance. They are depending on polymutation, P53 copy number, and the mismatch repair deficiency. From the molecular type, 4 molecular types are described. Poly-ultramutated, which is known to have good prognosis even in the presence of other high-risk factors. The mismatch repair deficiency, known to have intermediate prognosis. The P53 high copy number has the worst prognosis. On the other hand, the non-specific molecular profile, or the one with low copy number, P53 copy number, it also reflects an intermediate prognosis. So we have an excellent prognosis in the poly-ultramutated. We have poor prognosis for the P53 high copy number. We have intermediate for the other 2 types. The molecular subtype would affect the course of early stage only. Again, the new staging process, the new staging 2023, the main difference, we can recognize it in stage 1 and 2. Stage 3 and 4 were not affected much by the new staging. And the idea is to know the high risk prognostic factors based on the molecular types and other factors like the lymph vascular space invasion and histological subtype. Second, to save patients who have who are known to have a good prognosis according to molecular genetic makeup of their tumors, so that they can be saved the chemotherapy or adjuvant treatments. So high copy number P53, which is serous-like, is associated with poor prognosis even in presence of other favorable histology. On the other hand, the ultramutated poly is associated with good prognosis even in poorly differentiated histology. Patients with mismatch repair deficiency have intermediate prognosis, as I said. Patients with copy number low will have intermediate prognosis as well. FIGO staging 2023. Stage 1. Stage 1C, it appears for the first time, but it doesn't reflect positive cytology as in 1988, but it reflects aggressive variety, which is confined to a polyp or to the endometrium without any invasion. Stage 1B is the same, I mean, like in 2009. It is non-aggressive, more than or equal 50% of the myometrial thickness. What about stage 1A? Stage 1A can be subdivided into 3 subclasses. The non-aggressive only endometrial involvement will be stage 1A1. 1A2 will be non-aggressive with less than 50% myometrial invasion. Stage 1A3, which is, as I described it before, as the confusing one, it is non-aggressive type, confined to the 1 ovary and to the endometrium without deep myometrial invasion, and it should be of grade 1 or 2, without substantial lymph vascular space invasion. Prerequisite of stage 1, it should be no or focal lymph vascular space invasion, no substantial space invasion. So if it is present, lymphovascular space, substantial lymphovascular space invasion, it is going to upstage the stage. If aggressive histology, it should have no myometrial invasion in order to be considered as stage 1. So, in staging 2023, stage 1A, 1A1 confined to the endometrium, 1A2 less than 50%, 1A3 low-grade endometrioid ovarian tumor associated with endometrial carcinoma. Stage 2, patient can be assigned to stage 2 if in the past it was only stromal invasion of the cervix. Now it is either anatomical extension to cervical stroma, as we said before, so it is stage 2A, or stage 2B if there is substantial lymphovascular space invasion, even in the absence of cervical invasion. It's still in the corpus, but with substantial lymphovascular space invasion, or the presence of aggressive subtype with myometrial invasion. It's going to be stage 2C. So, in the past, it was only stromal cervical invasion makes it stage 2, but now we have substantial lymphovascular invasion and aggressive subtype with any myometrial invasion. Stage 2A, stromal invasion. Stage 2B, non-aggressive with substantial lymphovascular invasion. And lastly, 2C is aggressive type. What about the molecular classification? This is the most recent type or recent part of the staging. It is called the molecular staging, and it is assigned as M. We add M to it. So we have stage 1A, M, to stand for molecular polyultramutated endometrial carcinoma confined to the uterine corpus with or without cervical extension, regardless of the lymphovascular space invasion or histological type. This means that this molecular subtype has a very important role defining the prognosis, even in the presence of high-risk factors. On the other hand, the other extreme, stage 2CM, P53 high copy number. It is endometrial carcinoma confined to the uterine corpus with any myometrial invasion, with or without cervical invasion, and regardless of the degree of lymphovascular or histological subtype. So we can determine the extremely detrimental effect of high copy number P53. Figure staging, stage 3, I will not waste your time. It is almost the same, no big deal. Maybe there is just macro invasion of the of macro and micro metastasis of the lymph nodes. It's no big deal, I think. Stage 4 have been added the 4C. In the past was A, B only, now A, B, and C. It's no big deal also, and doesn't affect the prognosis so much. In fact, we have some remarks on the staging 3 and 4. There's no much change, as I said. The primary goal of the new staging is to avoid under-treatment of poor prognosis patients with substantial lymphovascular space invasion or high-risk molecular subtype, and to spare patients with apparently aggressive disease that have favorable molecular profile. The final comment, now you can express both the anatomical spread, the histological type, and the presence or absence of substantial lymphovascular space invasion in only one stage or substage. Second, the gynecological pathologist should be aware of the staging so that they would comment precisely on the degree of lymphovascular space invasion, whether it is substantial or focal or none. And lastly, the meticulous examination of lymph nodes to differentiate micro from macro metastasis. Lastly, staging malignant tumors should be attainable in most areas around the world to help homogeneity of data and information. But molecular staging is extremely expensive. It's not available in most of the world. It's only in the blessed world, the first world, especially for limited resources countries. They don't have this facility. So by time, there will be a deep and wide gap between the same disease in different patients across the world. So this may necessitate worldwide action to make this molecular testing available worldwide. Thank you very much.
Thank you, Professor Salah. How much would it cost to do the molecular testing? In dollars? Very expensive. بسم الله الرحمن الرحيم. عارف ان احنا تعبنا مش كده؟
Now we will present Professor Dr. Ahmad Rami. He will give an idea about updates on human papilloma virus and
طيب بسم الله الرحمن الرحيم. اسمحوا لي نتكلم عن الاتش بي في والاتش بي في فاكسين، وكان في سبونسرد توك اعتقد من ساعه كده تقريبا على نفس الموضوع. الاوتلاين هنتكلم على البيردن اوف ذا ديزيز، الفيروس، الفاكسين، الافيكاسي، الاميونوجينيسيتي، the safety of the vaccine, الورلد وايد امباكت of the vaccine, international recommendations, gender neutral vaccination, call for action and handling some concerns. The global burden of the HPV related cancer and disease in males and females. Yearly we have around 690,000 cases of HPV related cancer are diagnosed in males and females around the world. In males, we have oropharyngeal cancer, recurrent respiratory papillomatosis, anal cancer, genital warts, and penile cancer. Whereas in females, we have oropharyngeal cancer, recurrent respiratory papillomatosis, cervical cancer, vulval and vaginal cancer, cervical dysplasia, anal cancer, and genital warts. Cervical cancer burden is high among women. It's the second most common cancer among women aged 15 to 44 globally, and 99% of cervical cancer is linked to infection with high-risk HPV. Every 2 minutes, one woman dies of cervical cancer worldwide. The thing is, maybe in the history of medicine, this is the first time to have a vaccine against cancer. We have vaccine against infectious diseases worldwide, and it's been implemented in most national screening programs worldwide. But this is an opportunity we should grasp, that we have a vaccine that protects against cancer, and yet the uptake rate is not as high as we would expect it. The WHO estimates that the worldwide prevalence of HPV in 2017 is 11.7 in women and 21% in men. In Egypt, the prevalence of HPV in women is 14.3 from 2019 to 2020. This was a study of the Egyptian population. HPV prevalence in women increased from 10.4 in 2010 to 14.3 in 2020. Of those who tested positive for HPV, majority were type 16, 27% showed more than one type, and 35% had CIN2 or 3. HPV-associated disease states. HPV is responsible for virtually all cervical cancers. 90% of the anogenital warts, a benign condition, are caused by HPV type 16 and 6 and 11. More than 90% of cases of anal cancer are caused by HPV. HPV positive oropharyngeal cancer represented 40% and a half of cases of oropharyngeal cancer before the year 2000 versus up to 70% since 2009. This is cervical cancer in Egypt is the 9th most common female cancer in women aged 15 to 44. Nearly all sexually active people are infected with HPV within months to a few years of becoming sexually active. By the age 50, at least 4 out of every 5 women will have been infected with HPV at one point in their lives. Most people who become infected with HPV do not know that they have the virus. And nearly all sexually active people are infected with HPV within months to few years of becoming sexually active. Around half of these infections are with high-risk HPV types. In low and middle-income countries, there is limited access to these preventive measures, and cervical cancer is often not identified until it has further advanced and symptoms develop. Like we mentioned before, more than 95% of cervical cancer cases is due to HPV infection. 2020 guidelines recommend that individuals with the cervix initiate cervical cancer screening at age 25 and undergo primary HPV testing every 5 years through ages 65 years. If primary HPV testing is not available, individuals aged 20 to 65 should be screened with co-testing, that's HPV testing in combination with a cytology every 5 years or cytology alone every 3 years. Early protection works better. An uninfected female receiving HPV vaccine prior to sexual activity protects against the types of HPV that cause most cervical cancer. When we get the infection with the HPV, for most people, the immune system will clear the infection with no harm caused. Either it's a high-grade abnormality or a low-grade abnormality. A low-grade abnormality will revert back to normal, while a high-grade will proceed to cervical cancer. When left untreated, uncontrolled growth of abnormal cells can become cancer. It takes at least 10 to 15 years for this to develop. The Pap test detects cells after the changes have occurred, whereas the cervical screening test can detect an HPV even before cell changes occur. HPV vaccination can prevent more than 90% of cancer caused by HPV from ever developing. So it provides a strong protection against new HPV infection and is preventive vaccination and does not cure an infection once the woman have it. So it's not used to treat HPV infection or disease caused by HPV. According to the European Center for Disease Prevention and Control, boys, including boys in the current HPV vaccination program, is likely to be beneficial for both genders. Gender-restricted vaccination programs, that's only girls has demonstrated a substantially lower effectiveness than universal vaccination. Protecting boys may also protect girls through herd immunity. So HPV infection, genital warts, and cervical precancer, abnormal cells on the cervix, have dropped since the vaccine have been in use in the United States. Infection with HPV types that cause most HPV cancer and genital warts has dropped 88% among teenage girls and 81% among young adult women. Among vaccinated women, the percentage of cervical precancer caused by the HPV types most often linked to cervical cancer has dropped by 40%. This is the structure of the HPV vaccine. It's a non-enveloped virus, exists as a genetic material, DNA, surrounded by a capsid, protein-infused material. A capsid acts to surround and protect this genetic material. It helps to bind to the particular cell that the virus needs to infect. So the HPV, we have cancer-causing types, mainly a high-risk group, 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, and 59, mainly 16 and 18. They are causing 70% of cervical cancer, and we get also protection against non-cancer causing types, mainly type 6 and 11, causing 90% of anogenital warts. So the natural history, like we just mentioned, we have an HPV infection, get a persistent infection, low grade, high grade invasive cancer, or infection may be transient and cleared. The most common route of HPV transmission is sexual contact. And here always comes the question that you are asked by the lady, where did I get the HPV from? However, HPV is a stable virus and can survive chemical treatment and still be able to be transmitted through non-sexual routes. Sexual routes, either heterosexual contacts, intercourse, oral contact, orogenital, hand genital, anal genital, oral anal contacts. Non-sexual routes, transvaginal ultrasound probes, underwears, childbirth, vertical transmission, very low risk, hand-to-hand contact, and we've been recently witnessing an increase in the rate of HPV from laser treatment in dermatology clinic, especially if it is a contact laser, if there is a touch laser. We see many ladies catching the HPV from this source of infection. So please be aware and tell your patients that they need to get the disposable part of the needle with them if they are to do laser treatment in dermatology clinics. Risk factors for infection include a younger age at first vaginal sexual intercourse, younger age at first oral sexual intercourse, higher number of partners, tobacco smoking, lower level of education, lack of insurance, a non-Hispanic black race, and the risk factor for persistence of the disease and in progression to cancer, infection with high grade and immunocompromised status, and co-infection with other sexually transmitted disease and tobacco smoking. Fortunately, we don't get these risk factors in our society, but actually in the developed worlds, they have this very prevalent in their society. So the vaccine, the concept, it's a viral like particle. HPV L1 are virus-like particle are structured genomically, geometrically, and antigenically almost identical to the native virion, but they lack the DNA and therefore are non-infectious. Current commercially available vaccines are non-infectious recombinant vaccines, prepared from the purified viral-like particles of the major capsid L1 protein of the HPV. They are highly immunogenic, and the resulting antibodies have been shown to be neutralizing and type restricted when tested in a pseudoviron neutralization assay. So we get a bivalent, a nanovalent, and a quadrivalent vaccine. The bivalent, the two high-risk types, 16, 18, the quadrivalent, 2 high risk and 2 low risk, 6 and 11, and the nano vaccine, includes 9 types, 2 low risk and 7, 2 high risk and 7 low risk virus types. So globally, if we have this, what we just mentioned, we would expect that the uptake rate would be at least 70 to 80%. But actually, this is not the case. Globally, HPV vaccination rates are low. As of 2019, only 4% and 15% of eligible females and 4% only of eligible males were fully vaccinated globally. Can we do any better? Sure we can. So what do we get? We get a vaccine with 98% efficacy, 100% efficacy in case of VIN-23 and VAIN and vulval and vaginal cancer. We get with anal cancer 75% efficacy. We get with genital warts 89% efficacy in males and 99% efficacy in females. This is an article in the New England Journal of Medicine addressing HPV vaccination and the risk of cervical cancer. The study used a nationwide registry data in Sweden following 1.7 million girls and women who were aged 10 to 30 between 2006 to the year the HPV vaccine was approved in that country, 2017. It demonstrated that the risk of developing cervical cancer was reduced by 88% in women who had been vaccinated before the age of 17 and by 53% in those vaccinated by the age 17 to 30. Greater risk reduction among women who were vaccinated before the age of 17. So we have to vaccinate, and we have to vaccinate early. Is the vaccine safe? Over 270 million doses of HPV vaccine have been worldwide distributed. The vaccine appears to be extremely safe. HPV disease burden in males is as big a problem as in females. High prevalence, no screening, low natural immunity, and a high reinfection rate. So HPV, as we know, in women or in females can lead to cervical, vaginal, vulvar, anal, head and neck cancer, genital warts, and recurrent respiratory papillomatosis. In males, also it can lead to penile, anal cancer, genital warts, and recurrent respiratory papillomatosis. HPV infection are prevalent in males and females across multiple age groups, and natural immunity is not a reliable preventive strategy. International recommendations: children and adults through ages 9 to 26 routinely recommended at the age of 11 to 12. Vaccination can be given starting at the age of 9. Catch-up HPV vaccine is recommended for all persons through ages 26 who are not adequately vaccinated. More than 26 years, catch-up HPV vaccine is not recommended for all adults above 26. Instead, shared clinical decision-making regarding HPV vaccination is recommended for some adults with high-risk behaviors, 27 through 45, who are not adequately vaccinated. HPV vaccine is not licensed after the age of 45. So we don't give it to ladies above or males above 45. Schedule: before the 15th birthday, it's 2 doses, 0 and 6 to 12 month schedule. After 15th birthday, it's 3 doses, 1, 2, and 6 months schedule. This is shows where we are in the global HPV vaccination. Countries in blue are, it's a national screening program. Maybe as you can see, and we're outside خالص. Subnational, demo complete or projected still national screening program. We have 120 WHO member states have HPV vaccination national program. 29 additional countries projected to have HPV vaccine on a national program. immunization program by the end of 2023. Libya is one of the countries. Saudi Arabia is one of the countries. Morocco is one of the countries. Bahrain is one of the countries. We're not there. WHO Director General calls for all countries to take action to help end the suffering caused by cervical cancer. The statement is, no woman should die from a deadly disease that is both preventable and curable. Thank you.
Next speaker will be Dr. Yusuf Abu Alwan. Title of the speech, Heavy Menstrual Bleeding in Adolescents.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه. First of all, I'd like to thank the organizing committee and specifically Professor Dr. Hatem Al-Jamal and his colleague for inviting me to this outstanding conference. The title of this session is Conditions Overlooked by Gynecologists. I just read it, يعني أنا لسه قاري العنوان كده. I'll speak about heavy menstrual bleeding in adolescents, who to investigate and how to manage it. الحقيقة أنا مش عارف ده overlooked ولا يعني موضوع مهم ولا مش مهم. نشوف كده، طالما أنا هتكلم فيه يبقى أكيد موضوع مهم. This is Zagazig. This is the city from which I came. It's about 90 kilometers away from here. This is adolescents. These adolescents represent how much of the population? And they deserve to speak about them. Yes, the statistics say that there are about 1.2 billion adolescents in the world, comprising about 16% of the population. يعني رقم لا يستهان به. What about the topic I'm speaking about? Heavy menstrual bleeding. This is the most common gynecological reason for referral of adolescents to secondary care. So I'm speaking about important disease to a very big population. NICE defined heavy menstrual bleeding, as we know, it's excessive menstrual loss. This is what I want to stress upon. Any bleeding impact individual quality of life. Quality of life is very important. It's not a matter of changing pads, or it's not a matter of days of bleeding to say heavy menstrual bleeding. Heavy menstrual bleeding if it's impaired socially. She is inviting for any social reason. رايحة معزومة في فرح أصحابها أو عندها خطوبة أو عندها خروجة، مش قادرة تروح بسبب الهيفي menstrual bleeding أو بسبب المنسترويشن دي. It's a problem. ده الهيفي menstrual bleeding. لو affect السوشيال باك جراوند بتاعها ده it's a problem. A small introduction about the menstrual cycle of adolescents. Like the adult, it's ranged from 2 to 7 days, occurs from 21 to 45 days. This is a very important, this statement. In the first year, following menarche, 50% of menstrual cycles are anovulatory. Once I said it's anovulatory in the first year after menarche, the most common cause of heavy menstrual bleeding in adolescents is anovulatory cycles. But after this 1 year, they become ovulatory and most of them improved by time. Also, by 2 to 3 years post-menarche, 75% of adolescents are ovulating regularly. So most of these problems are self-limiting. The most common cause of heavy menstrual bleeding in adolescents, as I just know, is an ovulatory cycle resulting from hypothalamic pituitary ovulatory axis immaturity. So the majority of heavy menstrual bleeding are due to anovulatory. These are well improved by time, 2 to 3 years. So heavy menstrual bleeding commonly improves with time. And reassurance may be all that some adolescents and their carers is needed. At this point, I can stop my talk because most of it's self-limiting. So reassurance, once ovulatory or after 2 to 3 years, the hypothalamic pituitary ovarian axis will become mature. But still, there is some cases they will not improve. This is a checklist if we are going to properly define just frequency, duration, frequency, just by ticking, so it will tell you it's heavy menstrual bleeding or it's affecting hair cycle. Once again, this is the adolescent. What about the etiology? Etiology of any abnormal uterine bleeding is palm coin. Is it applied for the adolescent? No. There is no time for polyp or leiomyoma or malignancy or hyperplasia, as my eminent professors just speak about endometrial cancer or how to prevent cancer cervix. No. Palm coin is not, yes, you can apply it here, but pointless. How to clinically evaluate heavy menstrual bleeding? Like any bleeding, like any disease, history, examination, and the investigation. History, menstrual history, and these are, you know it very well. What about the examination? General examination or local examination for adolescent with heavy menstrual bleeding, is it of value? No. It will not add for you anything. What about investigation? When you will investigate and what you are going to investigate, what laboratory test you want to do? Simply CBC or full blood count, including serum ferritin. This is to know if it's affecting general condition or no. Fortunately, these girls can withstand hemoglobin up to 4. I saw many cases and I manage them. Hemoglobin is 4 and still they don't complain and they are going to school, but they impair their life. In addition to CBC, we will do a coagulation profile, including fibrinogen, prothrombin, ABTT. The other things which you have to do is just von Willebrand disease screening. Just try to the laboratory screening for von Willebrand disease. Von Willebrand disease, if we don't, because we are gynecologists, we are not hematologists, but just you have to know it's one of the most common cause of bleeding disorders in adolescent is von Willebrand disease. Its subtypes, as I will mention just after maybe a few minutes. The second thing which you have to investigate, hypothyroidism. Hypothyroidism can cause this heavy menstrual bleeding by increasing TSH and low thyroxine level. Maybe polycystic ovary. It's if you find you want to investigate it, you can sexually transmitted and urinary pregnancy test. You can do it with meticulous restriction. This about the laboratory investigation. What investigation other than the imaging? Just ultrasound, of course, abdominal ultrasound for adolescents. And in our community, it's pointless to tell you do perineal ultrasound or transrectal. Yes, it can add. The radiologist or the sonographist will tell you it will be more, but we will do abdominal ultrasound for the adolescent to just to know if there is abnormal thing or not. It will tell you most of the cases are normal. So what is the pathological cause of heavy menstrual bleeding? As I just mentioned, bleeding disorders. Once it's heavy menstrual bleeding from the onset, or there is history of recurrent epistaxis or bruising or family history of bleeding disorders, you have to put in your mind maybe bleeding disorders. As I just mentioned, von Willebrand disease is the most common bleeding disorders. This is in UK and here also. These are the subtypes: type 2, type 1, type 2, and 3. Because of your time, I will skip them. But I just want to tell, when I was candidate for ASOGIC exam, came to us a question: von Willebrand disease type 3 and pregnancy. It was classified as one of the difficult question. Fortunately, I passed this question, but unfortunately, I failed in the dysmenorrhea in ASOGIC. But just to remember that von Willebrand disease. We are no need to know the types of von Willebrand disease, but you have to put it in your mind. Even if you don't put in your mind, I will tell you how to overcome this. The other blood disease which can cause heavy menstrual bleeding is thrombocytopenia. ITB, immune thrombocytopenia. This represents about 70% of ITB can be presented with heavy menstrual bleeding. Other hemophilic subtypes. After the bleeding disorders, as I mentioned to you, hypothyroidism, you can, these are, all these, the other diseases can cause. Some drugs, especially anti-epileptic drugs, can cause heavy menstrual bleeding. Just to put in your mind, in medical history, some medication can cause this. What about the management? As I told you, the management mainly reassurance. Most of the bleeding disorder of heavy menstrual bleeding are anovulatory, and it will improve by time, except if it's recurrence or affecting the general condition of this patient. Who will manage this heavy menstrual bleeding? Of course, the gynecologist. But you can have hematologist with you. If you find it's a bleeding disorders, you can ask for pediatric hematologist. I used to manage with a pediatric hematologist, especially cases well known with the blood disease. I don't know the blood disease, but I know how to control this heavy menstrual bleeding. Of course, psychologists can help us in everything. We want to prescribe some drugs. يا دكتور اكتب لي روشتة، أنا عايزة أعالج العيانة دي بعد ما قلت لها هتتحسن. It will improve with time. The first line, the ladies like it, is non-hormonal medication. And in top list, antifibrinolytic. And top list, tranexamic acid. You can give tranexamic acid 1 tablet TID. It will reduce this heavy menstrual bleeding by half. About 50% will be reduction in the flow. This is fine. You can add ibuprofen and pediatric dose. It will also add a benefit. Unlike the adult menorrhagia or heavy menstrual bleeding, mefenamic acid, don't prescribe it for the adolescent. As I want to tell you, every words you have read or hear from me, it's from the ASOGIC April 2024. ده آخر حاجة في الكلام يعني قالوه. ما تنساش تبرسكرايب ايرن عشان هي وطبعا ما فيش أكتر من الايرن في الدنيا. The other line of treatment is the hormonal. The first line, if you don't know how to manage or you don't know blood disease, just prescribe combined oral contraceptive pills. It will help you too much. Senile estradiol, of course, 30 microgram, and addition to any progesterone, levonorgestrel, it's whatever, all are the same. If they don't like oral contraceptive pills, well and good, prescribe progesterone. And this is a recommendation by the British people. They like the progesterone. And I belong to British, I'm Egyptian, and I'm from the village people, and I am proud of that. Progesterone is the only you can prescribe progesterone. If you are they don't like oral contraceptive or they don't compliance with it, any type progesterone. Progesterone only belzizogestrel you can give it. Norgestrel you can give medroxyprogesterone Provera. You can make withdrawal bleeding every 3 to 4 months if she have PCO. If they are not compliant with the daily dose يعني مش هتقدر تاخد الحبايه كل شهر، اديها حقنه منع الحمل كل 3 شهور. ديبو مدروكسيبروجسترون اسيت very cheap, very effective و it's good. Myrina, if you have time I can tell you a real story for adolescent, but it was married. Her hemoglobin was 4 and she was suffering from ايوه adolescent بس متجوزه بس وبتتعالج من الانتي فوسفوليبيد سندروم وعندها لا عندها ثرومبوزس وبتاخد هيبارين والهيموجلوبين بتاعها 4 واهلها جايبينها بيقولوا اعمل شيل لها الرحم من البليدنج اللي عندها ده. ركبت لها الميرينا وبامر فضل ربنا هي جت كده يعني وما كنتش اعرف. اترفع الهيموجلوبين ل 12 وبعد كده جم قالوا لي عايزه تحمل شلنا اللولب وحملت. فدونت فورجيت ايوه هي ادولسنت بس في بريجنسي ادولسنت بريجنسي. ما ننساش الناس الحلوين دول سبيشال سيركمستانسز اللي هم الادولسنت والزيفي منسترال بليدنج وعندهم ليرنينج ديسابيلتيز ومشكله عليهم وعلى اهاليهم تو اول هير فاميليز. نو بروبلم نو نيد ان انا اخلي المنسترويشن تيجي كل شهر، ما انا اخليها تيجي كل 4 شهور. ادي اورال كونتراسيبتيف 4 شهور كونتينيوس. مش هتقدر تاخد الاورال كونتراسيبتيف اديها الانجكشن، مش هتقدر تاخد الانجكشن بلاش الاورال عشان خاطر استاذ يعني. الاخر انا بقول لكم الهيفي منسترال بليدنج ده كومن كونديشن ومش اوفرلوكد ولا حاجه احنا بنشوفه، بس انا هلخصه لكم بكلمتين صغيرين. ان هو اصلا ديو تو في الاول هايبو اماتيوريتي اوف هايبوثالاميك بيتويتري اوفيريان اكسس واللي هو هيصلح نفسه بس مجرد ان انت تطمنهم. لو مش هيطمنوا الحاجه لو عايز تعمل يو ونت تو بريسكرايب دراج ترانكزاميك اسيد ibuprofen. if she improved it's okay they are satisfied by it because it will reduce the menstrual bleeding by about 50%. This is well and good. Not responding you can give progesterone or oral contraceptive pills. I'd like to thank you all and أخذت وقتي بزيادة. شكرا.
Can I call for the next speaker, please? Professor Ayman Abdel Fattah. He will give us a talk. Professor Ayman Abdel Fattah, he's head of the vascular surgery department at Ain Shams University. He will give us a talk titled Pelvic Venous Insufficiency, Standards of Reporting. تفضل Professor Ayman.
Assalamu alaikum. First of all, I would like to thank the organizing committee headed by Prof. Hatim Al-Jamal and Prof. Amr Al-Husseini for their kind invitation and their marvelous symposium. Today we'll speak about the pelvic venous insufficiency standard of reporting. Pelvic venous insufficiency is the new term for pelvic venous congestion, because before this pelvic venous congestion syndrome was not fully understood Now, with the advance and more orientation of the physician, more well understood pathophysiology and proper line of management now is considered pelvic venous insufficiency or disorders. Chronic pelvic pain is like a pelvic migraine that affects women in a childbearing period and was defined as chronic non-cyclic pelvic abdominal pain of at least 6 months duration. It is well defined nowadays. It will define disease. According to Milga Garnier, pelvic congestion syndrome is classified according to pathophysiology into 3 categories. And as I mentioned, the term pelvic venous insufficiency or pelvic venous disorder is used rather than the old term pelvic congestion syndrome. What is the classification? Type 1, which is primary venous valvular reflux pathology. Type 2, obstructive pathology. And type 3, local gynecological cause. Traditional therapy for treatment of pelvic venous insufficiency has included both medical conservative treatment and surgical approach. However, with the advantage of the endovascular minimally invasive techniques, now the endovascular procedure being minimally invasive is the main line of treatment of pelvic venous disorders. Number of previous studies were relatively small in comparison to the both burden of the disease and number of real cases. Also, most effective embolic materials and methods have not been established yet. Some authors describe the presence of lower limb varicose veins secondary to pelvic venous insufficiency and correlate its recurrence with the pelvic leak points, as we will show now. Why we are in need or we are in need for more scoring and classification system? Because there is some question to be answered. Still, why the same venous pathology causes different symptoms in cohort patient? Why the same symptoms in cohort group were of different venous pathology? Together with the well-established and studied the pathophysiology, which now we know that we have 4 venous systems, zones, reservoir, together with the pelvic leak points. All of these raises the issue to have more efficient scoring and classification systems. These are the zones. Now it is well. Okay. These are the zones and systems. Zone 1, including left renal vein receiving left gonadal vein. Zone 2, gonadal and internal iliac vein with the pelvic venous plexus. Zone 3, pelvic origin of extra pelvic veins like inferior gluteal vein, internal pudendal and external pudendal veins. And zone 4 is the lower extremity veins, whether the superficial or deep system or perforators. Let us study the pathology. This is the main pathology we have, which is primary reflux. If we can see, there is the monitor, please. Yes. أنا عايز بس pointer please. ها؟ تمام ماشي اوكي السهم اللي عندي هنا اوكي we will see. We'll start with the left upper part, which is compensated left renal vein compression. Left renal vein compression, which is called the nutcracker syndrome. If compensated, it will be on expense of pelvic reservoir, and so patient will present with pelvic symptoms. While if uncompensated, if we shift to the left side, left upper, this will not be compensated, so it will be on expense of the renal reservoir, renal venous reservoir, and so patient will present with renal symptoms. This is why different patient will, with the same pathology, will present with different symptoms. Also, left common iliac vein compression. This compression of the left, which is May-Turner syndrome, if this compensated, it will be on expense of the pelvic floor, and patient will present with lower limb symptoms and varices. While if not compensated, it will be on expense of the pelvic reservoir, and patient will present with pelvic symptoms. This is a new classification system for the pelvic venous disorder, which is the symptom varices pathophysiology. This is according to ESVS 2020. This classify all the presentation according to symptoms first, no pelvic symptom taking 0, renal 1, pelvic taking 2, extra pelvic, whether genital or leg symptom or venous claudication. Presence of varices, no pelvic varices take 0, renal varices take 1, pelvic varices take 2, extra pelvic take 3, whether genital or leg varices. For the anatomy and pathophysiology together, they take the whole veins starting from the inferior vena cava down to the leg veins, and the pathology here may be refluxing, obstructive, and if obstructive, it is whether thrombotic, non-thrombotic, or congenital. Also, there is modification of the classic SEEP classification. Okay, this classification has added to the clinical part with the recurrent active venous ulcer, and to the etiological part, congenital and no cause identified, and to the pathophysiological part, no pathophysiology identified. And for the anatomy, the most important, it takes the whole deep veins, abdomen, pelvis, and lower limb, starting from inferior vena cava up to the soleal plexus of veins. And this recent classification has included the pelvic varices and symptoms. What about the guidelines? For this, all guidelines from our society, European Society for Vascular Surgery, for patients with varicose veins of pelvic origin without pelvic symptoms, pelvic vein embolization as initial treatment should be performed. We are treating symptomatic patient. If the patient has varices, pelvic varices, but no symptoms, no treatment directed to the pelvic varices. For patients with varicose vein of pelvic origin with pelvic symptoms requiring treatment, pelvic vein embolization should be considered to reduce the symptom. This is the first line of management, is embolization. For patients with suspected suprainguinal venous obstruction, in addition to full leg duplex assessment, ultrasound of the abdomen and pelvis of the pelvic vein should be considered as a part of initial treatment. This is the most recent ESVS 2022 guidelines regarding pelvic venous insufficiency. For female patients with pelvic vein and clinical suspicion of pelvic venous disorders, exclusion of other causes of pain is recommended. This is here the gynecologist plays the maestro in such disease, not only because most of 2/3 presented to the gynecology clinic first, okay, but also because if the patient presented to us with varicose vein and suspected pelvic venous disorder, we have to refer to the gynecologist first. Please exclude local gynecological cause, which is the commonest cause for pelvic pain and pelvic problems. For patients presenting with symptomatic varicose veins, where there may be a pelvic origin, specific duplex ultrasound of pelvic escape point is recommended. We have a title of our varicose vein, which is called extraaxial or lateral varicose veins. And most of these cases are due to pelvic leak points from pelvic venous insufficiency. For female patients with suspected pelvic venous disorders, abdominal and or transvaginal ultrasound should be considered to confirm the presence of venous pathology. For patients with varicose veins of pelvic origin without pelvic symptoms requiring treatment, local procedure for varicose veins and related pelvic escape point should be considered as initial therapeutic approach. If patient has lateral or extraaxial varicose vein and had pelvic varices but no complaint of the pelvic varices, treatment will be directed to pelvic escape point. Usually we are injecting them either foam sclerotherapy or glue therapy, and then we treat the lower limb varicose vein as our schedule and as our rationale for treatment. We'll do some illustration. All of these cases done in our vascular and vascular department in Ain Shams University. اقدر استخدم عايز استخدم الماوس ازاي؟ الماوس استخدمه منين؟ ممكن مونيتور لو سمحت؟ ايوه تمام. اوكي. هو شغال طيب طب انا اعمل ازاي؟ الماوس لكن الماوس انا محتاج ماوس.
لسه ما بيظهرش عليه ايه؟ لا لا ده ايه؟ لا ليزر بس
بيطلع ليزر بس مش باين قوي. على الشاشه ما بيظهرش. تمام. Okay. If you can see here how much dilated left ovarian vein with complete arcuting and siphoning to the right side. And here there is also extension down to parauterine veins. This is before treating with embolization. This after treatment here with cyanoacrylate with the glue injection. If you can see here also, this is one case of left gonadal vein dilatation, also with siphoning to the right side together with parauterine veins. And here there is extension to the vaginal and vulval veins. This after coiling, we can see here this is the coil, okay? After coiling of left gonadal, obliteration of the whole venous reflux. This is different case after embolization. This A and B after injection of foam sclerotherapy using Tessari method. You see complete obliteration, no siphoning, no arcuting, and all of these after coiling. Here we can see the coils here with complete obliteration of the left gonadal veins. Left gonadal reflux is or left ovarian is the most common reflux. However, sometimes we are seeing right gonadal or right ovarian vein reflux, and we have to manage. Okay, if you can see here, this is right gonadal reflux. Indeed, the right gonadal is a tributary for the inferior vena cava directly. Okay, here also all of these right gonadal together with parauterine and paravaginal vein, and this is actually after coiling. As we see in this case, we make coiling for both gonadal, both ovarian. This is the right, and this is the, this is the left, and this is the right. We see this patient with very huge very huge right gonadal vein dilatation, and this is also after coiling. This is the same also bilateral coiling. Here you can see bilateral coiling of gonadal with complete obliteration. I mentioned before about the pelvic escape points, which is very important pathophysiology for our extraaxial or lateral varicose vein. This pelvic escape points, this is escape from the refluxing pelvic venous to lower limb veins. I will show some of these points. As you can see here, this is the B point, this is the pudendal point, which is the reflux here of the vein. Do you see? This patient will present with vulval and vaginal varicose veins. As you can see here, this is around the round ligament, which is the inguinal point. This patient will present with inguinal varices and lateral thigh varicose veins. This is the G point making sciatic varices, which is varicose vein in the posterior aspect of the thigh along the course of sciatic nerve. Here the obturator, one obturator with the obturator veins, and this will present with medial thigh varicose. For conclusion, Mr. Chairman, and for take-home message, we have to be more meticulous in diagnosing pelvis venous disorder, because still a considerable number of cases are missed or undiagnosed. A combination of trans-abdominal or transvaginal ultrasound assessment of pelvic veins with routine venous duplex study of lower limb is mandatory when suspecting pelvic cause of varicose veins of extra or extraaxial varicose veins. In symptomatic patient with pelvic venous disorders, we have first to exclude local gynecological cause, which is, as I mentioned before, the gynecologist is the maestro for diagnosis and direction of the patient of such disease. If definitely local gynecological case is evident, he will manage. But if no identified local gynecological cause, he will refer to the vascular surgeon. Please, this patient has venous disorders, you have to manage this patient. With the use of new scoring and classification system, this facilitated diagnosis, categorization, and follow-up after management. The best tool for management of patients with pelvic venous disorders with the main pathology is reflux is endovascular embolization. A combination of coiling and injection proved to have the most effective and the least recurrence, which is our practice in our Ain Shams University Vascular Department. We combine injection, whether foam, sclerotherapy, or glue, with coiling. This proved actually evidence-based practice that it will be the most effective with the least recurrent. Thank you.
Thank you, Dr. Ayman Abd-Fattah, for your nice presentation. I would like to invite our next speaker, Professor Dr. Muhammad Hamid, who will address us about uterine niche, many myth and truth.
مساء الخير تشير بيرسونز، الساده الحضور. انا دكتور محمد حامد، استاذ مساعد امراض النساء والتوليد في كليه الطب جامعه عين شمس. ان شاء الله نكون موضوع حديثنا عن موضوع يوتراين نيش، many myths and few facts. طبعا الوقت متاخر وحضراتكم اكيد بتسمعوا كلام كتير من الصبح من اساتذتنا وزملائنا الافاضل، فهنحاول نكون مختصرين معاكم على قد ما نقدر. اولا احب اشكر الدكتور حاتم الجمل وكل اللجنه المنظمه واللجنه العلميه للمؤتمر العظيم، مؤتمر قسمنا اللي نتشرف ونفخر به جميعا، وما شاء الله كل سنه من نجاح لنجاح. أم، هنتكلم عن اليوتراين نيشز او السيزيريان سكار ديفكت او ايا كان الاسم اللي احنا هنناقشه معاكم. What is a cesarean scar niche? A cesarean scar niche also is named or called as esmocele, uterine niche, uterine diverticulum, or pouch. It was first described in 1961 by Boydevine, and it's essentially a discontinuation of the myometrium at the site of the previous scar. And this gives the appearance of a hypoechoic area on performing ultrasound scan. ليه بنتكلم عن اليوتراين نيش وليه مخصصين له محاضره وليه بقى فيه many presentations بتتكلم عن اليوتراين نيش؟ هل هي فعلا مشكله ولا much ado about nothing، الكثير من اللغط على لا شيء؟ في الحقيقه اليوتراين نيش في increasing body of studies about the prevalence of uterine niche. It's estimated that about 50 to 60% of women with history of cesarean section in general will have a uterine niche. هل ده بيزيد؟ هل ده موجود؟ هل ده جيني ان ذا باتل عفريت احنا حضرناه ولا بنتكلم عليه، ولا هل فعلا في rising incidence؟ It's difficult to quantify the incidence of uterine niche بسبب different study and different diagnostic modalities. بس in average it's found between 24 to 70% of women submitted to ultrasound scan, transvaginal scan, and a slightly higher percent ranging from 56 to 84 using saline infusion hysterography. It's estimated that women with previous 3 cesarean sections will almost all of them have a cesarean scar niche. تقريبا اي patient حضرتك تشوفها في العياده بعد 3 cesarean section almost confirmed ان هي عندها uterine niche. طيب عرفت ان موجود uterine niche وعرفت انها مشكله وon the rise we are increasingly frequent problem. ايه مشكله اليوتراين نيش؟ ليه عاملين القصه ديت عليه؟ uterine niche بالاضافه الى ان هو a cause of many gynecological symptoms زمان كانت unexplained او unknown etiology زي abnormal uterine bleeding، وبالتحديد for the history taking لحضراتكم بيكون post menstrual spotting بالاساس. بالاضافه الى الديسمنوريا والكرونيك بيلفيك بين وليد وفر انفيرتيليتي، وهنتناقش وهنتعرض للنقطه دي بالتفصيل بعد كده. فin addition to the gynecological problems and symptoms it causes also obstetric problems. دلوقتي احنا بقينا بنشوف كتير حالات من السيزيريان سكار اكتوبيك، وبقينا بنشوف حالات كتير من البلاسينتا اكريتا سبيكترم، وكل ديت احنا طبعا عارفين الكومبليكيشنز والمشاكل بتاعتها. in addition وهنتكلم على ده بالتفصيل بعد شويه، ليه implication على الفيرتيليتي potential of the women سواء during spontaneous pregnancy او even pregnancy with assisted reproductive techniques. طيب لما نشوف اليوتراين نيش وعرفنا ان هو بيعمل المشاكل ديت كلها، ليه different parameters during imaging احنا بنعلق عليها او بنهتم بيها. منها السايز اوف ذا uterine niche, its depth, its location بالنسبه لليوترس، والريزيديوال myometrial thickness او thickness of the endometrium overlying اليوتراين نيش. طيب ايه اهم فاكتور في الفاكتورز ديت؟ المفروض يبقى في سيستماتيك بريسكريبشن في الايمجنج لما حضرتك تبعت عيانه او حضرتك تصور عيانه بتعمل ريبورت الترا ساوند ليها او MRI وات ايفر. بس لقينا الموست امبورتنت بارامتر، ودي هنتكلم عن النقطه دي بعد كده، هو الريزيديوال مايوميتريال ثيكنس. لان الريزيديوال مايوميتريال ثيكنس لما نقيسه ده ليه امبليكيشن بعد كده على التريتمنت موداليتي وعلى الريسك فاكتورز اللي العيانه هتتعرض ليه في حاله وجود اليوتراين نيش. فبالتالي مهم جدا during imaging of patients with previous cesarean section. واحنا عرفنا دلوقتي ان تقريبا كل البيشنتس اللي هيجوا لحضرتك في العياده previous 3 cesarean section is almost confirmed انهم عندهم uterine niche. ف it's very important to measure this very important parameter, the thickness of the overlying myometrium او residual myometrial thickness. طيب ليه اليوتراين نيش بيحصل وليه بقينا بنشوف حالات كتيره منه، وايه اللي ممكن نعمله عشان نتجنب وجود هذا اليوتراين نيش بعد ما شفنا كل الجاينيكولوجيكال سيمبتومز والاوبستريك ريسكس اللي هي associated with uterine niche. في many studies اتعملت for the assessment of different risk factors for uterine niche, investigated many factors in the etiology of uterine niche. لأن الموست important and most significant risk factor for the development of uterine niche following a cesarean section is the low uterine incision أو low hysterotomy site during a cesarean section. The pathophysiology behind this etiology is possibly incorporation او ان احنا اخدنا معانا cervical tissue. cervical tissue زي ما حضراتكم عارفين it's mucus producing tissue. mucus production incorporated او داخل في السوتشر لاين بتاع حضرتك هيؤدي الى poor healing وبالتالي poor scar formation and the development of uterine niche. في عندنا many other contributing factors اهمهم نتطرق ليه cesarean section during labor لما يكون العيانه in labor بالذات لو more advanced in labor وده مش related بس لان هو ده بيؤدي الى ال cesarean scar incision اللي بيتعمل بيكون low لا ده كمان بيكون associated مع ischemia و higher risk of infection. Similarly لما تكون الهيد ستيشن low during cesarean section لو البيشنت was in labor for a long time و it was a finding ان لما حضرتك تعمل بلادر فلاب او تزق البروتون تحت during cesarean section لقوا ان دوت ليه ريسك فاكتور for the development of uterine niche possibly بسبب اسكيميا انفكشن مش عارفين. طيب احنا اغفلنا علشان نتطرق بقى بالتفصيل للسيزاريان سكشن كلوجر تكنيك و long standing debate and discussion and controversy about the technique of cesarean section and its effect on the development of uterine niches and the development of rupture uterus and dehiscent scars later on. في من studies الحقيقه with conflicting data بس astonishingly غير ما احنا نتوقع من الكومن براكتس والريكومنديشنز والتريننج اللي بنقوله للنواب ان ما لاقوش ديفرنس كبير بين السنجل والتو لاير كلوجر اوف ذا سيزاريان سكشن وده الحقيقه كان evident in many studies حتى الستاديز اللي قالت ان في difference between single layer and double layer uterine closure قالت ان هو it might lead to higher residual myometrial thickness بس not in fact does not affect the incidence of future uterine niche development. فبالتالي ده خلى في study very recent لسه منشوره الشهر اللي فات في سبتمبر 24 قالت ان ال findings do not support favoring one closure technique over the other وده حتى يعني بيتحدى الريكومنديشن والجنرال تيتشنج اللي احنا بنقوله كلاسيكال تيتشنج ان تو لاير كلوجر از مانداتوري فسابوها for the discretion of the surgeon single layer or double layer. بس يعني قبل ما نسيب السلايد دي for the teaching purposes and for the classical training in obs and gynae I think we'll still recommend two layer closure rather than single layer closure until we have future evidence. بس يعني scientifically speaking we still don't have an evidence to favor either single or double layer closure. وبرضه قبل ما نسيب دي الحاجه اللي فعلا في evidence against اللي هو احنا نعمل locking sutures اللي هو بيلوك كل غرزه في اللي قبلها ده بيؤدي الى more ischemia. طيب هل السيزاريان سكشن ليه امباكت على الفيوتشر فيرتيليتي زي ما احنا قلنا؟ هل لو عيانه ما عندهاش اي حاجه وهي عندها secondary infertility following cesarean section هل اليوتراين نيش اللي احنا لقيناه هل دوت cause of infertility ولا ده مجرد associated findings؟ statistically speaking الحقيقه لقينا ان women with previous cesarean section عندهم lower incidence of implantation زي ما حضراتكم شايفين 24 versus 36 or 37 almost percent والpregnancy rate even عندهم اقل 40% versus almost 55%. طيب هل لما نعالج اليوتراين نيش هل ده بيحسن الفيرتيليتي بوتنشال بتاع العيانه؟ الحقيقه ان في عندنا ستادي ان الديفرنت تريتمنت موداليتيز اللي احنا هنتكلم عليها سواء هيستوسكوبيك او لابروسكوبيك are associated with improved fertility potential and achieving spontaneous pregnancy سواء بعد هيستوسكوبيك correction او بعد لابروسكوبيك correction ده حسن الفيرتيليتي potential وده ياخدنا للنقطه الديبيتبل او الكونتروفيرشال اللي بعد كده الكوركشن از ات لاباروسكوبيك اور هيستروسكوبيك. طبعا مش هنتكلم على فاجينال ريبير ولا هنتكلم على اوبن سيرجري هنركز على الحاجات المين عشان مش عايزين نطول في المحاضره زياده عن اللزوم. في ارجيومنت لاساتذتنا البرو هيستروسكوبي او مؤيدي الهيستروسكوب ان احنا عندنا ايفيدنس ان الهيستروسكوبيك نيش ريسكشن is associated with improvement of symptoms much especially in terms of post-menstrual spotting. In the hysteroscopic approach, we have better access to the lateral edges of the niche. يعني لما نيجي نتكلم على اللابروسكوبيك ريبير لو حضرتك عارفينه بنابروتش النيش من فوق فاللاترال edges بتبقى hidden behind the uterine arteries. فدي one of the arguments that hysteroscopy is better. طبعا بالاضافه الى النيت advantages of hysteroscopy ان هو an easier procedure, shorter hospital stay, less complication, lower cost. ولكن ده بيكون على حساب الريزيدوال myometrial thickness، لان الهيستروسكوبي actually it erodes او removes the inner side of the uterine niche leading to reduction of the residual myometrial thickness. علشان كده عينين عندهم low residual myometrial thickness hysteroscopic excision of the niche may further reduce the residual myometrial thickness. So based on expert opinion, we suggest that residual myometrial thickness is left for patients with residual myometrial thickness more than 3 millimeters. On the other side, the pro-laparoscopy side, they have results that laparoscopic resection of the uterine niche leads to symptomatic improvement, and it actually is, it seems to be more anatomical. We are restoring the anatomy. زي ما لما حضرتك بتفتح في السيزاريان سيكشن بتشيل السكار القديمه وبتخيط فريش ايدجز، ده نفس اللي بيتعمل في اللاباروسكوبي. بل بالعكس ده بيدينا انكريز في الريزيدوال مايوميتر ثيكنس، زي ما بعض الاستاديز لقت ان الريزيدوال مايوميتر ثيكنس انكريز from 2 ملم up to 9 ملم. ومش بس كده، ده قالوا ان دوت ايفن هذا الافكت it continues after cesarean section. يعني لما حضرتك تعمل لاباروسكوبيك نيشر سيكشن لبيشنت والعينه تيجي لحضرتك بعد كده بعد ما عملت قيصريه مع حضرتك او مع غيره، بروفايدد ان احنا عملنا السيزاريان سيكشن بكوركت تكنيك، فحضرتك هتلاقي ان الريزيدوال مايوميتر ثيكنس از ستيل preserved after laparoscopic resection. فبالتالي الاكسبرت اوبينيون that the laparoscopic resection is preferred in patients with residual myometrial thickness of 3 millimeters or less. يعني في الاخر نعمل ايه برضو؟ لجأنا لبيبر في الجورنال اوف مينيمال انفيزيف جاينيكولوجي، وده الاوفيشال جورنال اوف ذا امريكان اسوشيشن اوف جاينيكولوجيكال لاباروسكوبيست. دي زي القشر كده لاخواننا اللي في الاوضه اللي جنبنا بتوع الانفيرتيليتي. الجايد لاين بتاعهم برضو ما حللناش المشكله. there is no sufficient evidence to favor the choice between hysteroscopy or laparoscopy. Based on expert opinion, expert opinion is the lowest level of evidence based medicine. They recommend doing laparoscopic correction in cases with residual myometrial thickness of less than 2.5 millimeters. فبالتالي هم essentially يعني قالوا لنا ايه، يعني اعملوا الصح، no definite pathology. محاولة توفيق الأوضاع في ناس قالوا نعمل كومباينيشن ما بين هيستروسكوبيك ولاباروسكوبيك كوركشن، فناخد الادفانتج اوف بوث، بس برضو احنا بناخد الديس ادفانتج اوف بوث اون ذا اذر سايد. ده سيف وافكتيف، ولقوا ان احنا بناخد الادفانتج بتاعت بريزيرفنج الريزيدوال مايوميتر ثيكنس، وكمان بنقدر ناخد بيتر اكسس لللاترال ايدجز زي ما قلت لحضراتكم they are better accessible by hysteroscopy. بالاضافه الى ميزه عظيمه جدا في الكومبايند هيستروسكوبيك اند لاباروسكوبيك تريتمنت، وهي الترانس اليومينيشن، لان احيانا باللاباروسكوبيك فيجن ما بنبقاش عارفين where the thinnest part of the myometrium اللي هو فيه مكان النش. فالهيستروسكوبيك ترانس illumination in combined hysteroscopy laparoscopy has this added advantage. طيب بعد ما عملنا هيستروسكوبيك نيش كوركشن واكتشفنا ان الايفيدنس فعلا كلامه مظبوط وان البيشنت الحمد لله حملت، نقول لها تستنى تحمل قد ايه؟ كنا نصحناها تستنى قد ايه قبل الحمل؟ مفيش ديفينيت جايد لاينز، بس يعني بالقياس لقينا ان احنا بننصح البيشنت زي بعد حالات المايومكتومي ان احنا to wait 6 months before attempting pregnancy. It seems reasonable، بس برضه we don't have definite studies. اللي فات ده كان كلام عن السيرجيكال ابروشز، او بمعنى ادق المينيمال انفيزيف سيرجيكال ابروشز. بس هل ده ينفي وجود دور لميديكال تريتمنت في حالات اليوتراين نيش؟ الحقيقه في رول للميديكال تريتمنت كسيمتوماتيك تريتمنت. هو مش هيستور المايوميتريال ثيكنس، مش هيعالج الديفكت اللي احنا شفناه في المايوميتريوم، بس ممكن يكون سيمتوماتيك تريتمنت للابنورمال يوتراين بليدنج بالذات البوست مينسترال سبوتنج، سواء عن طريق البيلز او عن طريق الهرمونال اي يو دي الانتروتراين سيستم، فلا ان هو افكتيف تريتمنت. اخيرا اسيمتوماتيك نيش زي ما قلت لحضراتكم، تقريبا اي عيانه والده 3 قيصرات او حتى ايفن 2 سيزاريان سكشنز جات لحضرتك في العياده، حضرتك عملت لها سونار هتلاقي ان في يوتراين نيش. هل هي بتشتكي منه او ما بتشتكيش منه؟ هل ده ليه امباكت على التريتمنت؟ فالاسيمتوماتيك او اكسيدنتال ديسكفر نيش do we treat or we do not treat the asymptomatic niche؟ الحقيقه الايفيدنس is towards not treating the asymptomatic uterine niches. حتى even يعني they suggest ان يكون السيمتوماتيك uterine niche مع ultrasound findings دي كاتيجوري او دي سندروم، والمجرد الالتراساوند فايندنجز بس دي يبقى سندروم تاني، زي ما بنقول مثلا في حاله البوليسيستيك اوفيريان مورفولوجي والبوليسيستيك اوفيريان سندروم، مجرد الابييرنس بالالتراساوند does not dictate ان انا عندي clinical syndrome that needs treatment. اخيرا يعني عشان ما نطولش على حضراتكم اكتر من كده، التيك هوم مسج uterine niches are on the rise along with the rising incidence of cesarean section. They are associated with both gynecological symptoms and obstetrical complications, and they are associated with subfertility, and most probably treating the uterine niches either hysteroscopically or laparoscopically will improve the fertility chances of the patients. The ideal surgical modality for treating uterine niches is still a matter of debate, but mostly the residual myometrial thickness will guide your decision towards either hysteroscopic or laparoscopic dissection treatment. And asymptomatic and accidentally discovered cases, they do not require treatment. And for cesarean section techniques, we don't have solid evidence, but I recommend and suggest keeping with the classical teaching of two-layered closure. بالتالي نخلي الريماركس في الآخر. And thank you very much for your attention.
مفيش حد تاني في. طب هات ال 10 ادفانسد اتس هات لي بس ال It's my pleasure to introduce Dr. Rohel Manschanda, isn't it? Anyhow, he is from our friend country from India. He will speak about Asherman syndrome, intrauterine adhesions, basics. Okay, most will come in Egypt. Looking forward to hear from Indian people. We are very close friends long time ago, and we will continue forever. Please, the floor is yours.
So, yes, thank you. We are friends and we will continue for a long time. I would like to thank, of course, the organizing board, Professor Bhatim, Professor Abdul Hamid, my friend, Professor Saeed, Mohammed Saeed, Mustafa Ibrahim, and Sheriff El Makawi for having me here. I'd like to thank Bart, who's there, Professor Bart from the ISGE. I must say, this is probably the last or the latest lecture. It's now 7:24. I haven't lectured this late ever in my life. The latest that I've ever lectured, this is of course me, and the latest that I've ever lectured was with this gentleman in the middle. I don't know if you recognize him. That's Professor Bitoki. We all use his hysteroscope, and we were traveling from Delhi to Pune, India, and we reached at about 5:30. I gave my lecture, and 6 o'clock he gave his lecture. So it's true. This session is about navigating conditions that are overlooked. And Asherman's is definitely overlooked, and I'll tell you why. Because Asherman's is, of course, the lower term. The umbrella term is intrauterine adhesions, and this is a book that we have written. And it is, believe you, the first book that was written, and it came out in 2021. Because, of course, this condition is quite overlooked, but when it does happen, it's quite unnerving for the lady. Now, I have no disclosures about this book. It came to me, I wanted to write this many years ago, and it came together, and I spoke to, if you recognize this gentleman, his name is Mark Emanuel. And he's done the maximum work on intrauterine adhesions. I asked him if he would write the foreword to the book, and he said if you rename it as intrauterine adhesions, and the reason he said was because the pathophysiology between intrauterine adhesions and Asherman syndrome is different. You need to have a pre-existing pregnancy for naming it Asherman's, and if it's not, then you call it intrauterine adhesions. So actually, intrauterine adhesions encompasses Asherman syndrome. This is a bit about the history. It was diagnosed or first brought to light by Heinrich Frisch way back in 1915, but Joseph Asherman has done the maximum amount of work. And that was not so long ago in 1948 when he worked on and he saw two conditions. One is the stenosis of the cervix and intrauterine adhesions inside the cavity. So he distinguished it between these two. Of course, for Asherman's, you needed to have a pre-existing, whether it's a trauma to the uterus due to a pregnancy, curettage, or postpartum infections, or postpartum curettage. That history is important. Now, these are the other two gentlemen who've actually written the foreword for the book. We had our book release in 2022 in Hungary. What are the synonyms? We all know all these conditions, and you can sort of interchange the name. But if we look at it, this is the history again. Frisch is the one who discovered it. Ashermans took it up and carried it out further. What happens? There are three types of adhesions inside the uterus. It could be endometrial, it could be myometrial, and it could be connective tissue. The last one is the most difficult to treat. What are the symptoms? You could have all these symptoms that are listed here: cramping pain, hematometra, absence of or decreased menses, infertility, and of course placental abnormalities. Taking a good history is very important for diagnosis of intrauterine adhesions. You will have a short history of decreased in periods amount. So you need to ask directed questions. This is some of the risk factors which we know, which is curettage. Also, intrauterine adhesions can be caused by intrauterine surgery, whether it's a myomectomy or it is an endometrial ablation or a metroplasty incision also. Now, what is the pathophysiology? Pathophysiology is trauma to the intrauterine endometrium causes inflammation. This surgical trauma then causes increased amount of cytokines and growth factors, fibroblast growth factors, which will cause fibrosis, and that will cause decreased, of course, in the arterial supply of the endometrium, causing all the problems that you can have. Let's go on further. Clinical diagnosis, a good history, followed by an ultrasound examination. And of course, the gold standard is a hysteroscopy. You do have saline infusion sonography that is there. Some of us are doing it, or a hysterosalpingogram. Many of us, when we work up our infertility patients, on a hysterosalpingogram will see these adhesions. The recommendations of the AAGL are very clear. A hysteroscopy is the gold standard for diagnosis. And if it's not available, then of course, you're looking at a hysterosalpingogram and the other investigations. What do you see on an ultrasound? The endometrium will be very thin. It'll be irregular. You might have bridging synecdoche. But of course, if you put in gel in the uterine cavity when you're doing the ultrasound or saline, you can have them demarcated better, the adhesions. So I don't do saline infusion sonography. I think it's better to put in a telescope and have a look hysteroscopically. And then, of course, treat it at the same time. So these are just some pictures that you see, which are of hysterosalpingograms. You have a normal picture on the left side. You have, of course, intrauterine adhesions on the others. Gold standard, as we mentioned, was a hysteroscopy, or is a hysteroscopy. These are some pictures that I'm showing you. It's important for any diagnosis and for management of any condition to have a standardized classification system. We did write a paper on this in 2016. We published our own classification system, which was then in this paper in 2021 ratified by a multi-centric and multi all over the world, different countries, authors from all of them. And you see the most common, of course, used classification system is the, which all of us know is the American Fertility Society, which is a very broad classification with lots of criterias. And ours is the last, which was 2016. And it is a very simple classification system, which essentially says that mild is when you have intrauterine adhesions which cover less than 1/3 of the cavity. Moderate is 1/3 to 2/3, and more than 2/3 is severe. The management according to AAGL is very clear. You have your diagnosis by hysteroscopy, you have your treatment with hysteroscopic adhesiolysis. To prevent readhesions, you have intrauterine devices, uterine balloons, stent, Foley's catheter. And then to restore the normal endometrium, it's the supportive treatment that you give, which is hormonal treatment, stem cells, PRP. A relook hysteroscopy is important, and we need to counsel our patients that you will have to have a relook hysteroscopy in order to make the treatment complete. Now, types of adhesions, like I said, you have the endometrial adhesions, which are thinner adhesions, which are best to treat. Very simply cut with your scissors under direct vision in a hysteroscopic setting. If you have, when you're cutting the adhesions, you can cut it with various things. You have mechanical instruments, which are the best, of course, because cautery is not there and there's no lateral damage to the already damaged endometrium. But you can cut it with cautery, you can cut it with a resectoscope, with a cold loop, you can even use laser. So success for anatomical restoration, though it mentions here 50 to 71%, but I would go to say that almost 80, 90% you can, a good hysteroscopic surgeon can correct the anatomy and restore the menses. Now, let's go on further. If you see this video, okay, let's see if I can, yeah. There we go. Normally, you would not have these adhesions which are wall to wall. A lot of times you find adhesions which are all around that sclerosis, which decrease the uterine cavity. But you have here a very simple sort of wall to wall adhesions. Very clearly, you cut them with a scissor in the center and you open up the cavity. This lady had these adhesions post missed abortion, which had been curetaged. She also had some fibroids, which we took out, but that's immaterial. So it's a very rewarding procedure if you can do it. The post-operative treatment is very important. And this is the protocol that we follow. We have mild Ashermans. We give conjugated equine estrogen. I normally give 0.625 milligrams twice a day for 21 days, followed by progesterone for 7 days. In moderate, we go up to 1.25 milligrams, that is 2 tablets twice a day. And in severe, you go up to the full dose, which is 2 tablets 4 times a day, followed by a withdrawal. Once she gets her withdrawal, you ask her again about her periods and her bleeding. It gives you an idea as to how successful your operation has been. And then again, you do a relook once she stopped that periods. So our protocol is to do a relook after that. Now, I'm not a fan of platelet-rich plasma, and what does the literature say? We're not sure it helps, but it's supposed to stimulate the growth factors for the endometrium inside and then help in the endometrium to regrow. It has a whole protocol. You have a two-step preparation for the platelet, and we have done a few cases in which we inject 0.5 ml in all 4 walls. But like I said, we don't normally, okay, let's, this video can, okay, there we go. Not working. There we go, thank you. So in Asherman's again, the problem is recognizing the anatomy, recognizing where to cut. And when we were doing the hysteroscopic workshop the other day, I think one of the trainees had asked me, how do you know where to cut? And the important thing is in laparoscopy, like you do in laparoscopy, you are, your anatomy is something you need to recognize. So you need to recognize the different parts of the uterine cavity before you know where to cut. So it's important to know that. And then of course there's ultrasound guidance which will help you. But in this video, if you saw, the anatomy is not visualized and that can cause perforations, which is what we had here. Now, these are some cases that you see. You have a tubular cavity on the left side, which was then after 3 sittings made into a triradiate cavity. Again, old videos. Yeah, thank you. And this one also. So this was a case of previous 3 cesarean section, a thick band in the center. You cut the band and you open up the cavity. Stay in the center. It's very important. And the end point is when, of course, like in a septum, you see the 2 osteas. But again, recognizing the anatomy is important. Can we play this video? Yeah. So the surface area which is left behind, which is white, will tell you whether you need to put in an IUCD or not. My protocol is to follow if there's anything between 2/3 and above, 1/3 and above is when I put in an IUCD, which is an inert device, taking the copper out, and then give her the post-operative treatment. Mild, normally we don't put in anything. Now again, the AAGL guidelines mention clearly direct visualization of the uterine cavity by hysteroscopy along with adhesiolysis is the treatment of choice for intrauterine adhesions. Extensive and dense adhesions must be treated by an expert hysteroscopic surgeon who recognizes what to do. Generally, T-shaped or copper-containing devices or LNG intrauterine devices are not suggested to be used. There is little evidence only for Foley's or the intrauterine device, which is inert, to be put in. There's still not enough information on that and RCTs. Post-operative hormone treatment also generally is not recommended, though we do give it in our protocols. The inherent hormones should take care of it. Vascular increasing substances are not recommended except in research protocols. And of course, abroad, not in our country, they're using hyaluronic acid gel, which is put post-operatively and is supposed to have good results. So our experience, coming to the end, we did a 5-year study, which we published also. And again, the take-home message is really that for institution of anatomy, for normalizing anatomy, for institution of periods, it's good. But the take-home baby rate still is low as far as pregnancy goes. Again, this is the book that we wrote, and hysteroscopy is a passion. These are the books which we have been privileged to write. And thank you very much once again for staying the course and for being here at this time, all of you.
هو اسمه ايه؟ انتوا بس تعرفوا. The best conclusions from Dr. Mustafa Ibrahim. He is professor of OB-GYN in Ain Shams University and the head of the scientific committee of this outstanding event. He will speak about agnocaston, climadinon, as a plant origin for treatment of some clinical condition. Bionorca. He will speak about.
السلام عليكم. معلش احنا جايين في اخر اليوم بس موضوع انترستنج وخصوصا في اليو تي اي during pregnancy. بسرعه كده نبدا. عارفين طبعا شركه بايونوريكا leading global company in research depending on research herbal medicine products. This is a portfolio of Bionerica. The first is climadinon for postmenopausal syndrome, Canefron Ono for UTI, and agnocaston. The first marvelous drug for treatment of UTI is a herbal drug called Canefron Ono. The problem in treatment of UTI during first trimester of pregnancy is to find appropriate drug which is safe totally to the fetus, which is not present in many of the antibiotics. You know, the drug of choice in treatment of UTI is levofloxacin, which is class D during pregnancy. So the challenge is to find a safe antimicrobial drug, herbal, which is called Canefron. Canefron Ono treat acute UTI during pregnancy and reduce the recurrence of UTI and increase the elimination of renal gravels, and also reduce the deposition of new renal gravels. كل الناس عارفه طبعا ان هو الدراج اوف تشويس في الفيرست ترايمستر is to use according to culture and sensitivity. Drug of choice in UTI during the first trimester, microdentine or nitrofurantoin, which has debatable studies on the safety of the fetus during the first trimester. And the use of macrodentine during third trimester increase the risk of neonatal jaundice. Canefron Ono is totally herbal drug. The composition of century herbal, lovage root, and rosemary leaves. What is the mechanism of action of Canefron Ono? The mechanism are the analgesic drug reduce the pain sensation, anti-inflammatory. So the use of Canefron Ono during first trimester equal the use of non-steroidal anti-inflammatory without the side effect of non-steroidal anti-inflammatory. Also has spasmolytic effect and anti-adhesive action which support flushing out of bacteria. This is the Canefron Ono in comparison to fosfomycin, which is drug used in the first trimester for treatment of UTI, single dose. The study shows that Canefron Ono is not inferior in treatment of UTI and also reduce the symptoms of cystitis as quick as antibiotic. According to the German guidelines for treatment of UTI during pregnancy, Canefron Ono classified as one of the best treatment for UTI during pregnancy. Ibuprofen and diclofenac and also Canefron Ono. في الجيرمان جايد لاينز بيبقى فيه زي برودكت نمبر كده for each drug. Caniferin ono has a number for these guidelines. Also, caniferin ono has add-on action added to the standard treatment of UTI, like levofloxacin, which is surely not used during pregnancy. So, caniferin ono reduce the cystitis, reduce biuria, and reduce cystitis recurrence. So, the issue during pregnancy for choice of antibiotic, especially in the first trimester, is to do urine analysis, then start herbal drug like caniferin ono, and then according to culture and sensitivity, we use the drug in the culture and sensitivity. And we can continue on caniferin ono for add-on therapy for 10 to 15 days. Caniferin ono used during first trimester was not associated with any teratogenic effect and relieve symptoms of biuria and reduce the frequency and the recurrence of pyelonephritis. The end point of this study, at least 14 days in the first trimester, Apgar scores of newborn whose mothers used the caniferin ono during first trimester is of good choice and does not affect the Apgar score. And the majority of newborn had scores of 10 to 8 to 10 points on Apgar scale, indicating that the condition was excellent and is totally safe during first trimester of pregnancy. Why caniferin ono? It is a novel herbal therapy with fourfold pharmacological action. What is the mode of caniferin ono during treatment of UTI? 4 actions. The first is anti-adhesive, second anti-inflammatory, and third is spasmolytic, and the last is analgesic effect. So it acts as antibiotic therapy and plus analgesic effect like paracetamol and non-steroidal anti-inflammatory. Also, according to the German guidelines, it used as non-antibiotic therapy for treatment of acute cystitis with 80% reduction in antibiotic use. Caniferin ono used for treatment of acute and recurrent UTI. And used as a standard treatment for treatment of renal gravels and renal stones. Caniferin ono is used as a safe drug during pregnancy, and the dose is 1 tablet every 8 hours for 10 days for uncomplicated case. And then we can use it for 1 month for recurrent attack and 3 months for recurrent attack and for recurrent acute pyelonephritis. So what is the strategy in treatment of UTI during pregnancy, especially in the first trimester? Is used a herbal drug like caniferin ono, then do culture and sensitivity. After culture and sensitivity, we can use the appropriate drug antibiotic therapy. If no growth of antibiotic, we can continue on the caniferin ono for 15 days. If there is a growth of an antibiotic, we can add on therapy, caniferin ono plus the appropriate drug according to culture and sensitivity. If there is a recurrent attack of cystitis, we can continue for 1 month. And if there is a recurrent attack of acute pyelonephritis, we can continue for 3 months. في بس نوت صغيرة كده, the use of antibiotic, especially in the third trimester, like macrodentine, can use increase the incidence of neonatal jaundice, and also the third generation cephalosporin induced what's called hematuria of the newborn. So be cautious in prescribing the third generation cephalosporin late in pregnancy, because it causes hematuria in newborn. Also, Bionorica for treatment of menopausal symptoms. There is a clamadienone. Clamadienone is herbal, non-hormonal therapy for treatment of menopausal symptoms. With special dry extract of black coach, which is not hepatotoxic, but in cases of patient with chronic liver disease, we must do liver enzymes every 3 months. What's the action of clamadienone? It is selective estrogen receptor modulator, agonist effect on brain, bone, and urogenital, with no effect on breast tissue and endometrium. Clamadienone significantly relieves menopausal symptoms with similar effect to conjugated estrogen and better than placebo. Also, clamadienone has a positive effect on the urogenital side symptoms of menopausal syndrome. So, clamadienone reduce menopausal related symptoms, similar effect to conjugated estrogen. Clamadienone reduce the hot flushes without side effect to conjugated estrogen, significantly reduce the psychological drawbacks of menopausal syndrome, increase the bone turnover index, don't change the endometrial thickness, reduce the side effect of breast cancer patients. عارفين في البريست cancer patient we use tamoxifen for treatment as a hormonal therapy. Clamadienone reverse the anti-estrogenic effect of tamoxifen. The dose of clamadienone is 1 tablet twice daily for 3 months at least, then repeated if need. The last product is agnocaston, which is also herbal drug. Agnocaston restore the balance between the estrogen and the progesterone and relieve the symptoms of moderate to severe PMS. And release and reduce the intensity of mastalgia and eliminate the menstrual irregularity and menstrual pain. So, what's the action of agnocaston? Lower the elevated prolactin level. It is the only herbal drug, or it is the only drug, non-pharmacological action with which you can use or decrease the level of prolactin without side effects. Relieve moderate symptom to severe symptoms of PMS, clinically to prove PMS associated mood changes, reduce mastalgia, and eliminate menstrual irregularity and menstrual pain, and is effective in treatment of primary dysmenorrhea. وفي طبعا دلوقتي في indication للاجنوكاستون. احنا عملنا ترايل على الاجنوكاستون ان هو برضو can be prescribed in functional ovarian cyst, can be used together with alfiltern in a dose of 1 tablet per day for 3 months, plus alfiltern 1 tablet before meal every 8 hours for 3 months. Okay, so we can revise agnocaston, clamadienone, and the first is canifron ono for treatment of UTI during pregnancy, which is totally safe and very effective and can be add-on therapy to other drug safe in pregnancy, and can be continued for treatment of renal gravels and recurrent acute pyelonephritis during pregnancy. Thank you.